Good day, everyone. This is Jim Moeller. I am the director of the Sports Medicine Fellowship at the Henry Ford Health System in Detroit, Michigan. Welcome to a recorded lecture series. Today is the first of a two-part series regarding what I call the highs and lows of sports medicine. It's an introduction to altitude and diving medicine. Just to go over the goals and objectives of today's lecture, we want to review the physiology of exposure to high and low altitudes. We want to review the effects of altitude on exercise, discuss illnesses associated with high altitude exposure, and discuss barotrauma injuries with illnesses associated with diving. Today, part one, will focus on high altitude. When we talk about altitude and altitude exposure, there are several physiologic responses that we want to consider. Changes in the hematologic system, cardiac system, and pulmonary system. When we talk about the hematologic changes, specifically, we look at increased erythropoietin production as well as blood volume changes. These hematologic changes, including the EPO production, will begin in as little as 1 hour after acute exposure to altitude. Now, we're not talking altitude of 100 meters. We're talking of higher altitudes, maybe 15 to 1800 meters and above. And this increased EPO production will stimulate red blood cell production. The blood volume changes are twofold. In the early stage, you have diuresis that will decrease the plasma and extracellular volumes and create a relative increase in hematocrit. Later, there is fluid retention. This, along with EPO, causes an increased blood volume. The increased erythropoiesis typically takes about 2 weeks to develop, so you have to have relative consistent exposure to altitude to get that benefit. Increased hematocrit can lead to blood viscosity and the issues associated with blood viscosity. Looking at some studies regarding blood volume and hemoglobin and hematocrit, we have to go back many years, but the numbers still hold up. Here is a study from 2002 that looked at 4 groups. It looked at untrained sea level native people, untrained moderate altitude native people, trained cyclists who are native to sea level, and trained cyclists who are native to altitude. And so this was comparing natives at sea level to natives of moderate altitude. So it is not someone who is acutely exposed to altitude. What you see is that in the untrained individuals, there is a big difference in hemoglobin and hematocrit when you compare the sea level person to the altitude native person. So UT is untrained, C is a cyclist, so they're the trained people. 0 meters are the sea level natives, and 2,600 meters are the altitude native people. And again, you can see that in the untrained group, there is a big difference in hemoglobin and hematocrit. These are statistically significant. When you look at the effects of altitude and training on these various groups, what you see is in the untrained group, there is a large altitude effect on total hemoglobin. And in the cyclist group, the light blue, you'll see there's also a statistically significant altitude effect. If you look at the difference from training, here are the sea level natives. Untrained has a much lower total hemoglobin than the trained. And then also, when you look at the natives of altitude, you see a significant training difference. Similar findings were noted in red blood cell volume, plasma volume, and total blood volume. As you see here, training effect was greater than altitude effect. So let's move on to cardiac changes that take place with altitude exposure. First, there's an increased blood pressure, both the systolic and the diastolic. but these levels will return to near sea level baseline within several days to several weeks. And this is due to activation of the sympathetic nervous system. Immediate increase in cardiac output is noted. And this is due entirely to increased heart rate. As you see on this graph here, this is a study, again, done many years ago, but the data still holds. 24 subjects were exposed to hypoxia, so a simulated altitude environment. The fraction of inspired oxygen was tested at 21%, which is room air, and again at 12.5%, which again is the hypoxic environment. And the immediate response to hypoxia was an increase in cardiac output, which is Q on this graph, by about 22%. And you can see that it was entirely due to heart rate. Stroke volume basically did not change. And so the oxygen delivery to the tissues remained unchanged, which is an important thing when you're at altitude and you want to exercise. So the human body, being the amazing machine that it is, made up the difference because the cardiac output exactly matched the decrease in arterial oxygen content. Cardiac output returns to normoxic baseline or even slightly less within several days. Heart rate remains elevated, but stroke volume decreases. And this all occurs prior to that polycythemia, which often takes a couple of weeks. So there must be improved oxygen extraction. And this is due to recruitment of inactive capillaries, which improves oxygen delivery. Looking at the pulmonary changes, the initial change is hyperventilation, which means overbreathing. It's not deeper breaths. It's overbreathing. Is how I look at it. So at rest, it starts with an increased tidal volume. And you'll see this up to about 3,500 meters, this increased tidal volume leading to hyperventilation. Increased rate comes in later as you get to higher altitudes, and all this leads to a respiratory alkalosis, which shifts the hemoglobin curve to the left, decreasing cerebral blood flow. Pulmonary artery pressure increases and endothelial permeability increases. And that's important as we look at the medical problems that occur with altitude. So, what is the effect of altitude on exercise? First, the VO2 max will decrease with acute exposure to altitude, approximately 1% for every 100 meters above 1,100 meters. This is worse shortly after rapid exposure, but will improve with continued exposure, although it may not reach sea level intensity. The VO2 max decreases as altitude increases in almost a linear fashion in altitude naive athletes. So again, going back almost 20 years, you can see that VO2 max and performance were compromised both in males and females at high altitude. For endurance athletes living near sea level and untrained subjects, a decrease in VO2 max has been observed at relatively low altitudes between 300 and 800 meters. And again, you can see from this graph that gender is another factor that influences sensitivity to hypoxia. Males have been shown to have greater performance decreases than females when measured at a particular altitude. If we go back to the study that we looked at before that looked at untrained athletes versus trained cyclists at sea level and altitude, and again, these are natives to sea level and natives to altitude, you can see that VO2 max is significantly impaired at altitude in untrained individuals. But when you look at the VO2 max in trained individuals, that effect is diminished. So again, VO2 max is lower in untrained individuals at altitude versus trained sea level subjects, where the VO2 max is similar in trained altitude and sea level subjects. So there is this acclimatization that takes place. Therefore, it's reasonable to assume that VO2 max in trained individuals living at altitude would further improve with training at sea level, leading to a competitive advantage. So let's look at exercise at altitude. Submaximal exercise, there's no immediate effect on EPO secretion, and it may cause a late onset rise in serum EPO. If you're performing maximal exercise at altitude, there's no immediate effect on EPO secretion, but you may hamper or decrease serum EPO. This reduction in serum EPO would not be beneficial for endurance athletes, so maximal training at altitude, and this is in altitude-naive athletes, would not be beneficial, which brings us to the live high, train low principle. And again, we're thinking about altitude-naive athletes here. So this is something that's generally practiced in endurance athletes, because athletes who are primarily in anaerobic sports, short burst sports, things of that nature, really won't benefit from this. But what happens is you perform altitude acclimatization in your living condition, which will increase EPO production, increase red cell volume, and increase blood volume. And your training you do at lower altitudes, so you eliminate the problem of decreased training intensity and eliminate the potential for decreased serum EPO if you're doing maximal training at altitude. In a Finnish study of 10 healthy volunteers, non-smokers, aged 21 through 34, 5 male, 5 female, all altitude naive, we look at the effect of intermittent hypoxia. These subjects were randomized to 7 days of either continuous hypoxia, 24 hours a day, or 12 hours a day of hypoxia. An altitude apartment was set at 15.4% oxygen, which equates to about a 2,500 meter altitude living experience. The continuous group never left the apartment for a week. The 12-hour per day group spent the evening and slept in the apartment for a total of 12 hours, and then the other 12 hours they were back at sea level doing their normal activities. And this was a crossover study, so the subjects were tested in both conditions in a randomized fashion, and there was a 2-month washout between the different trials. Blood was drawn at baseline and daily at 8 a.m. for most of the parameters that were followed. In the graph, the solid line is continuous hypoxia, and the dashed line is the 12 hours per day. And what you can see here is that the serum EPO significantly increased from baseline values during the first night in continuous and intermittent exposures both. There's no statistically significant difference on any of these days in serum EPO values between continuous and intermittent exposures. When you look at hemoglobin, there was no statistically significant difference. And again, this was only tested over a week, so we talked about how it takes up to 2 weeks of altitude exposure before erythropoiesis begins. So that's not terribly unexpected rather, in this situation. When you look at 2,3-diphosphoglycerate, this rose significantly on the very first morning in continuous hypoxia and remained on that significantly higher level through the rest of the exposure. Under the intermittent normal baric hypoxia, the 2,3-DPG showed a statistically significant rise from baseline from day 3 throughout the remainder of the exposure. No statistically significant differences were observed between the 2,3-DPG values measured during continuous and intermittent hypoxic exposures. Elevation of 2,3-DPG reduces hemoglobin's affinity to oxygen, which leads to better oxygen release to the tissues, which is an important factor for exercising athletes at altitude. If you consider the serum transferrin receptor measurements, and these were measured at baseline as well as on day 5 and day 7, the concentration rose significantly, and this confirms erythropoietic response to hypoxia. Finally, looking at reticulocytes, they showed a statistically significant rise on day 5 and 7 in both continuous and intermittent hypoxia situations. The late rise in reticulocyte count explains why there was no rise in the hemoglobin and hematocrit, but it does imply that a rise was on the way. The bottom line is that intermittent exposure to moderate normal baric hypoxia induces a similar stimulation to erythropoiesis as continuous exposure does. Therefore, you don't have to move to South America or Africa in order to get benefit. You don't have to live in La Paz, Bolivia, Bogota, Colombia, Addis Ababa. These are some of the highest altitude, highly populated cities in the world. In fact, you don't even have to move to Colorado, Arizona, Wyoming, or New Mexico in order to obtain this benefit. You don't have to be a native to altitude. You can get this benefit from intermittent exposure to altitude, such as in a personal altitude tent or an altitude apartment like we talked about in the Finnish study. A personal altitude tent costs around $600. The altitude generator costs nearly $5,000. But again, athletes can set themselves up in a situation where they are living high right in their own bedroom. Well, the question is, does it really work? And for some, it does. This is a graph of maximal performance test in runners who spent 18 days at a live high, train low condition. They were tested at baseline, and again, immediately at the end of the live high, train low experience, and finally 15 days later. So that's your post 1 is the day after, and post 15 is 15 days after the living experience was completed. And there was improvement in VO2 max in the live high, train low versus control, which was significant immediately at the end of the exposure. And though it was reduced as time went on, it did remain significant for the 2 weeks that were studied. So what about the people who permanently live at altitude? Can simulation of low altitude for training be of benefit because they're already natives to altitude? We saw that the hemoglobin and hematocrit over time probably equilibrates based on the Schmidt study. And we also see that their VO2 maxes will improve with continued exposure over time. So the people who are native to altitude seem to be able to compensate quite nicely. But what about simulating a low altitude situation for exercise and training? So Randy Wilbur and his team out at the USOPC in Colorado Springs worked on this, looking at the effect of FiO2 on physiologic responses and cycling performance. So he took 19 trained male cyclists from Colorado Springs, which is at an altitude of about 1,860 meters, and interval tested them 6 times at 100 kilojoules in 3 different oxygen situations: room air, 21%, at 26%, and again at 60% of FiO2. VO2 max, power output, and time to completion of the test was measured, and significant improvement in exercise performance was noted. The cyclists were unaware of the FiO2 used during the different tests, which was randomized with a 7-day washout between each trial. In this study, the 21% situation was considered the control trial, and the 60% was the hyperoxic trial. Time to completion of the workout decreased as FiO2 increased. Power output increased significantly with increased FiO2. And VO2 max increased significantly with increased FiO2. There's roughly a 5 to 8% improvement with each incremental rise in FiO2. So how do athletes obtain the benefit of live high, train low, obtain the benefits of the increased blood volume and red blood cell count? Well, you can do it naturally, which are acceptable methods. They're not technically natural. It's not natural to set yourself up to live in an altitude situation in your sea level apartment. But living at altitude, creating an altitude house or altitude tent, are considered acceptable methods to allow the body to naturally adapt to the altitude situation. But there are also banned methods like blood doping and the use of recombinant human EPO. Blood doping is the infusion of red blood cells to increase oxygen carrying capacity. It's a transfusion, usually of autologous donation. The history of blood doping is interesting. In 1947, it was first looked at as fresh blood transfused into military personnel was noted to lead to a 34% increase in their endurance. In 1984, 7 members of the U.S. cycling team were found to be doping at the Los Angeles Olympic Games. A study in 1990 of Italian athletes found that 1,000 of the 1,000 questioned, 7% admitted to trying blood doping. Potential adverse effects: bacterial contamination, infectious disease transmission if autologous blood is not used, and polycythemia. We talked about that thickening of the blood, which can lead to thromboembolic events and ischemic events. Acute hemolytic reaction is also possible with blood doping. When you look at the use of recombinant human EPO, it was first synthesized in 1987, and athletes found out about it and figured out how beneficial it could be in endurance situations. It was banned by the IOC in 1990. It has largely replaced blood doping because the side effect risks with regards to transfusion problems are eliminated. 7.6% of college athletes who use anabolic steroids also admit to using the RH-EPO. And again, these are those who admit to using steroids and admit to the use of EPO. So the numbers could be higher. The use of EPO does have adverse effects as well. The hyperviscosity of blood, which is really kind of the goal of the use of the EPO, can lead to the ischemic events and thromboembolic events that we discussed. Hypertension, flu-like symptoms, and hyperkalemia are also possible adverse effects. So when people cheat in sport, we need to try to catch them cheating because we want to have a level playing field. A urine test was developed for RH-EPO, and this was a test that used what's called two-dimensional gel electrophoresis. And WADA, the World Anti-Doping Agency, approved the use of this test in 2003, and it was also supported by the Court of Arbitration for Sport. Some international sport federations still use both urine and blood matrix for the detection of EPO, but it started out as a urine test. And again, only recently the urine test was adapted to blood to perform detection of some new erythropoiesis stimulating agents. And so all of this led to the need to be able to track athletes over time to try to catch the cheaters. And so it led to what's called the athlete biological passport. And this is based on longitudinal follow-ups of athletes' biological variables. So in order to further improve detection of abnormal blood profiles, WADA is leading the development of the strategy with this passport. The objective, which will be added to other anti-doping strategies, including traditional testing, is to detect abnormal variations of determined biologic variables in order to better target testing and or sanction those who are found with abnormal variations. There are many, many parameters that are tested and followed using the athlete biological transport, both hematologic and steroidal issues. So abnormal blood profile scoring, which is a combination of 7 blood biomarkers: hematocrit, hemoglobin, immature reticulocyte fraction, mean corpuscular hemoglobin concentration, All these things are followed. The mean corpuscular volume, the off-hour score, which is a combination of hemoglobin and retic percentage, platelets, red blood cell count, red blood cell distribution with standard deviation, retic count, retic percentage, white blood cell count. All these things are followed, as well as the steroidal modules and tests that are followed. And so what you end up getting on your passport is something that looks like this. The blue line is the value measured in the athlete for each marker each time they are tested. And the number of tests are on the horizontal axis and the values are on the vertical axis. The red line defines the limits, both the upper and the lower limit, of natural variation calculated by a software algorithm. And so what they want to make sure of is that the athlete stays basically between the red lines. If they fall outside the red lines, then they are subject to more testing, potentially even sanctioned if they fall well outside the red lines. So we talked about living high and training low and the benefits of that for endurance athletes. We talked about the physiology of altitude exposure on blood, heart, and lungs, and the effect on training. What about living low and training high? A common feature of the Live Low, Train High studies is that hypoxic exposure only during exercise sessions is not sufficient to induce changes in hematologic parameters. And collectively, these studies have failed to yield a clear picture of this training concept's effects on VO2 max power output during incremental testing or time trial performance. But it's something that athletes are looking into and physiologists are looking into as well. There is evidence that hypoxic training is beneficial for competition at altitude. So if you're going to run a cross-country race in La Paz, Bolivia, it may be helpful to train at altitude because that's where you're going to be competing. It's difficult to make recommendations until more data on performance in hypoxia after hypoxic training become available. We just don't have a lot of data on that. After training in hypoxic conditions, subjects have shown a decreased concentrations of free fatty acids, total cholesterol, HDL cholesterol, and LDL cholesterol, decreased homocysteine levels by about 11%, and a decreased maximal systolic blood pressure. And again, we're going back 20 years to get this data. So from these results, the authors in this particular paper that I'm citing concluded that hypoxic training might be beneficial for patients with cardiovascular disease. Let's now get into the medical issues associated with altitude exposure. The primary disease processes that we talk about include acute mountain sickness, high altitude cerebral edema, or HACE, and high altitude pulmonary edema, or HAPE. Some general information about acute mountain sickness. The incidence is about 25% for the altitude naive people who have acute exposure to altitude, and it's most commonly seen at elevations above 2,500 meters. Children and adults are at similar risk, and exercise will exacerbate the risk of having acute mountain sickness. Athletes and non-athletes seem to be at similar risk. What are the risk factors for AMS? Rapid ascent, the ultimate altitude achieved, and individual susceptibility, people who've had previous AMS, and people who generally are altitude naive, so for those who live permanently below 900 meters. The ultimate altitude is becoming an interesting factor because more and more people are participating in activities that take them to extreme altitudes. This is a photograph of the queue for people waiting to summit Mount Everest in 2017. Looks to me like there are 300 plus people waiting to get to the summit, which is insane to me that it's become such an industry to summit Mount Everest. But they tend to move up in a fairly rapid order. Many of these people are untrained. Many of these people are natives to sea level and are altitude naive, and they put themselves at risk for various medical problems. Symptoms of AMS usually occur 6 to 12 hours after arrival at altitude, and they're generally vague: headache, anorexia, nausea with and without vomiting, fatigue, dizziness, sleep disturbance, all of these things. Diagnosis is generally based on history in the appropriate environmental setting, as the exam is typically normal. AMS is defined as a Lake Louise score of 3 or more points from the different 4-rated systems, but headache has to account for at least 1 point, and it has to be in the setting of recent ascent or gain in altitude. Now, the authors of the Lake Louise AMS score advise to use this for research purposes only and really not for diagnosis, but a lot of folks have gone on to use this as a diagnostic tool. Sufficient research is lacking to divide the score into severity rankings, but for those who wish to do so, it is suggested that 3 to 5 points would be considered mild acute mountain sickness, moderate would be 6 to 9 points, and severe would be over 10 points. And again, headache must be at least 1 point in this score. So for patients with AMS, mild cases, rest, hydration, analgesics as needed are helpful in treating the symptoms, and descent is often not needed. In more severe cases, descent is important, along with supplemental oxygen and the use of acetazolamide or dexamethasone. Moving on to high altitude cerebral edema, it is possibly the end stage of acute mountain sickness. The physiology is theorized that hypoxemia leads to neurohumoral and hemodynamic responses which cause increased cerebral blood flow, increased vascular permeability, and eventual cerebral edema. The history of the patient with HACE is often the same as the picture of AMS in the beginning, which then progresses. The hallmark feature of HACE is confusion, and exhaustion may also be present. On physical exam, ataxia may be noted, altered levels of consciousness, which may progress rapidly to coma or death. Ocular changes may be present, including retinal hemorrhage and papilledema, and focal neurologic deficits are sometimes noted. The most important component of treatment is descent from altitude. Supplemental oxygen is an important component of treatment as well, but you shouldn't wait to get the oxygen before you try to get them down from the mountain. So if you don't have oxygen with you, don't worry about getting oxygen on them before you start the descent. Start the descent first. Corticosteroids can be beneficial, as can diuretics such as acetazolamide. Looking at high altitude pulmonary edema, this typically starts 2 to 4 days after arrival at altitude. This is a non-cardiogenic pulmonary edema. Remember, we talked about the vascular permeability in the pulmonary system back when we were talking about the physiologic response to altitude exposure. Exaggerated pulmonary hypertension leads to overperfusion and vascular leakage. The history of the patient with HAPE can start with an AMS picture, but not always, where in HACE it often starts with an AMS picture. Dyspnea is the hallmark feature of HAPE, as one would expect. Initially, this dyspnea is present on exertion and eventually can become present at rest. The person suffering from HAPE will have decreased exercise tolerance, and a cough is usually present, which starts as a dry cough, but advances to a cough with blood-tinged sputum. On physical examination, tachypnea, tachycardia, low-grade fever, and crackles on lung auscultation are often noted. Eventually, chest x-rays are obtained, and they may be nonspecific. And ECG will show tachycardia and right ventricular strain due to the increased pulmonary pressure, and low oxygen saturation will also be noted. Treatment for HAPE, such as it is with the high altitude cerebral edema, is descent from altitude. You have to descend to help the patient recover. Supplemental oxygen is another important aspect of treatment. Supplemental oxygen can reduce pulmonary artery pressure 30 to 50% and increase the arterial oxygen pressure, which helps reverse the effects of HAPE. Diuretics are of benefit, as well as nifedipine, which can reduce the pulmonary pressures. Corticosteroids are not as helpful with HACE as they are with HAPE. It would be great to prevent altitude sickness, because we certainly don't want to see people with the problem that we need to treat, even though we know how to treat these things. So some tips are: ascend gradually, maybe descend for rest and for sleep. And then in high-risk individuals, acetazolamide for prophylaxis can be of benefit. Now, acetazolamide has traditionally been avoided in people with allergies to sulfonamides. Crossover reactivity between antibiotic and non-antibiotic carbonic anhydrase inhibitors is unlikely. So perhaps acetazolamide can be administered to patients with a history of antibiotic sulfonamide allergic reaction, but again, traditionally they've been avoided. So let's get into a couple of questions here. This is taken from the AMSSM CAQ guide, and these are actual CAQ questions that appeared on past tests. In order to improve athletic performance, endurance athletes may train at altitude or utilize altitude in other ways to benefit them. Which of the following is true of the technique? A, sleeping and training at altitude provide best performance improvement. B, altitude training only improves performance for athletes of lower fitness levels. C, the altitude required to create benefit is 3,000 meters or greater. D, athletes with iron deficiency anemia can gain significant benefits from this training technique. And E, the training effect can persist for 3 weeks after returning to previous living altitude. So pause here and think about your answer. The answer is E. Beneficial effects of training at altitude can last for several weeks. Now, training at altitude is best if the competition would be at altitude, but again, the effect of living high and training low can last for several weeks. We go back to the slide where this was discussed, so you can see again that immediate post live high situation, the effect was quite significant, but the significance persisted for 2 weeks in this study, but it can last for up to several weeks, certainly. If we go back to the question itself, sleeping high, training low provides a better response than sleeping and training at altitude. When you look at foil B, athletes of any fitness level could benefit from this. Looking at C, the optimal training level is between 21 and 2,500 meters. And looking at D, patients with low iron stores won't benefit as well because they can't increase their red blood cell production appropriately. 2 nights after rapid ascent from sea level to an elevation of 3,500 meters, a non-acclimatized climber is experiencing symptoms of headache, dry cough, decreased exercise performance, tachypnea, and tachycardia at rest. In addition to descent, what is the most appropriate treatment for this climber? Dexamethasone, high-flow oxygen, ibuprofen, furosemide, IV fluids. Again, pause here and come back when you have an answer. The answer is B. This climber is experiencing symptoms from high-altitude pulmonary edema. Primary treatment includes descent and high-flow oxygen. Supplemental oxygen can reduce pulmonary artery pressure 30 to 50%, and increased arterial oxygen pressure helps reverse the effects of HAPE. If we go back to the slide where we talked about the treatment of HAPE, again, descent from altitude, supplemental oxygen, which could be in the form of hyperbaric oxygen or continuous positive airway pressure. Diuretics can be helpful, as well as nifedipine. Remember, corticosteroids are not as helpful in HAPE as they are in HACE. So if we go back to the question and look at the other foils, the dexamethasone is really not as helpful as it would be in a high altitude cerebral edema picture. when you look at foil C, ibuprofen could help with the headache, but does little else for patients with HAPE. Furosemide has not consistently been shown to be helpful, and loop diuretics may have certain types of problems that we don't want to encounter. IV fluids are not indicated because they have increased permeability, and if you increase their fluid volume, you could actually cause greater problems with the edema. Nifedipine has been shown to decrease pulmonary vascular resistance and should be considered as an adjunctive therapy if necessary, and could also be used as prophylaxis, but that was not one of the options. Other prophylactic medications include phosphodiesterase inhibitors such as tadalafil and sildenafil, as well as salmeterol. A climber crests 2,500 meters and experiences headache, nausea, fatigue, significant confusion, and ataxia. The most appropriate treatment option for this condition is which of the following? A, rapid descent, B, corticosteroids, C, calcium channel blocker, or D, nonsteroidal anti-inflammatory drugs. Pause here and come back when you have an answer. The answer is A. This patient has high altitude cerebral edema, as noted by the confusion and ataxia. Rapid descent and oxygen are the treatments of choice. Corticosteroids and diuretics may be helpful, but are secondary treatments. Going back to the slide where we talked about this, again, descent from altitude, supplemental oxygen, corticosteroids, and acetazolamide or other diuretics. When you look at these test questions, and this is true throughout, what I suggest is you look for keywords in every question. In this case, the keywords are confusion and ataxia, which led you to the diagnosis of high altitude cerebral edema. In the HAPE question, it was the dry cough and the tachycardia and the tachypnea, which were the key words that tipped you off on what the diagnosis was. And again, same in your foils. You want to look for keywords that will lead you to select or deselect a particular answer. But again, those are some sample questions from former CAQs on the topic of altitude medicine. I thank you for your attention today. That is the end of part 1 of this series of lectures. If you enjoyed this and you want to participate in part 2, the diving medicine lecture, I invite you to do so. I hope this was helpful for you. Have a great day.